All right, everybody. So hopefully this comes through just fine. As I'm doing my first EMS training here as the new bureau chief. Wanted to start by talking about capnography, shock, and the respiratory assessment. And so kind of the reason we started with this is something that we use every single day, whether you know it or not. So every patient encounter that we have an opportunity to use capnography. And that's not to say that we should always use capnography. I'm not saying that whatsoever. I'm saying that it is an underutilized tool, mainly because a lot of people just don't quite understand what it's for. So when capnography first came on the scene, a little background, it was really touted as a tube placement device. So we can really confirm the presence of an ET tube. And absolutely, we can do that, right? Because when we intubate someone, we put the capnography on the top of the tube. It gives us a nice waveform, and we know that we have a definitive airway. Works on an eye gel. It works on any other airway device that we would put on. So that was kind of how it was, but it wasn't really taught or understood or widely conveyed what else it does. So quite simply, we're going to go through how to read that. So it deals with shock, it deals with the respiratory patient, and really it deals with every single patient you encounter. My goal is after this that you have a better understanding of the uses of capnography, and more importantly, what your patient looks like and what's going on inside their body. So we're going to talk about the relationship between pulse ox, end tidal, and your body's pH levels. We're going to talk about what a VQ mismatch is. So we're going to bring back some paramedic and EMT language. We're going to talk about different types of shock, the 3 stages of shock that you can go into regardless of the cause of your shock. And then given a set of vital signs and some patient presentations, you're going to figure out what's wrong with them. So we'll work through a couple patient sims through this PowerPoint. And again, part of this is because we have a lot of new providers coming on the scene. So we have our guys that are just graduating paramedic school or about to graduate. We have some new guys going through paramedic school. We're doing a new hire. So we're going to be getting some new guys on here pretty soon. We also have some older providers where this was not a thing, right? Capnography was never a subject in any EMS education up until about really 2015, 2016, 2017. So only over the last 10 years has it really been there. And even in the last 10 years, it hasn't really been discussed much. A lot of discussions are taught poorly. So again, it's our goal to kind of clean that up, make you feel better, make you feel more comfortable with what you're seeing. So we're going to talk about respiratory patients because, well, shortness of breath is a very common dispatch. We go to a lot of trouble breathing calls, and we have different seasons of respiratory illness, right? So we have flu season. You can't turn on the news without hearing about the flu season or RSV or a combination thereof. What that does is it makes data collection extremely difficult. So you can go on the CDC's website and you can see exactly how many RSV cases there have been in a given month. You can see how many influenza cases there are, but you can't see like long-term trends. So it's hard to pull out, well, how many respiratory patients have been hospitalized nationwide? How many respiratory patients have we actually been on? Because we can go on a sick person call as well, and it's actually a respiratory patient. We can go on an altered mental status call, and it's a respiratory patient. And then what is a respiratory patient? So the point is that it's very difficult for us to figure out what is and is not a well-defined concept. But COVID, RSV, and influenza are all very common causes. But you can also have COPD, right? So chronic obstructive pulmonary disease, congestive heart failure, asthma. You can have flash pulmonary edema. You can have acute myocardial infarction, STEMIs and non-STEMIs, pulmonary embolism, anaphylaxis, pneumothoraxes, the simples and the tensions, and then trauma, right? So pulmonary contusions, broken ribs, all of those can lead to respiratory components and causes of shortness of breath. So there's a lot of different things that cause dyspnea or shortness of breath. And we need to try to not only figure out the cause, but how to treat them. And that's because every disease process requires an in-depth assessment. So in a respiratory patient, we have always touted pulse ox, pulse ox, pulse ox, pulse ox. However, SpO2 is not the sole indicator of hypoperfusion. So hypoperfusion being shock. We have to look at the patient in totality. So how's their airway? How's their work at breathing? How's their skin color and condition? What are their vitals telling us? It's not just pulse ox. Pulse ox is a great device. It's an awesome tool, but it has limitations. So number one is the little laser beam that shines through your finger to give you a pulse ox reading. Well, you have to have a pretty good nail bed. So if you have, dark fingernail polish on, if you have like acrylic nails, that is going to severely limit pulse ox capability. If you have been part of a toxicological event, so like carbon monoxide poisoning, pulse ox is going to read falsely high. You'll see 100% SpO2 when that patient is anything but. And also consider like the environment. So if you're very, very cold, right, because we're trying to take an assessment in February, well, your fingers are going to cramp up. You're going to pull your cold temperature to your body's core to stay warm. So you're not going to get a good reading. So before you get a pulse ox on those patients, get them in the ambulance or get them someplace warm their hands up, and then get a reading, or else it's going to read low. That's because it's measuring the amount of hemoglobin saturating at your fingertip. So if you have 98% of your fingertips saturated in hemoglobin, well, then we just assume and deduce that you must be 98% over your body. And that's a good way of doing it. But we pick your finger because it's easily accessible, it's distal, it's pretty away from everything else. And so you have to have a lot of capillary beds for gas exchange. But again, there are some false positives to pulse ox. It's not the only device. Just a quick airway anatomy review as well. So like what defines an upper airway versus a lower airway? And that's the glottic opening. So that's actually the opening to the trachea where your epiglottis is. So with lower airway sounds, that's where you're going to hear like rails, crackles, bronchi, wheezing. So those are your lower airway sounds. So where I'm actually listening to lung sounds. Your upper airway sounds are going to include snoring, stridor, and then your agonal or gurgling sounds. So if I'm hearing like snoring and stridor, that's an upper airway problem, right? I don't really need to listen to an auscultate. I can, but there's a difference between upper and lower airway treatment. If I have an upper airway problem, start thinking like foreign body airway obstruction. Start thinking about things like croup and epiglottitis. Lower airway problems, well, now I'm back into my COPD, my asthma, maybe my congestive heart failure. So each one of those has different treatment modes. And that's why this isn't a one size fits all. On top of all that, remember that your body's always trying to maintain homeostasis. So that's the balancing kind of all things. Your respiratory drive, the thing that makes you breathe and work, is based on the amount of CO2 in the bloodstream. It's known as your carboxylic drive. In COPD patients, that's different. It goes to a hypoxic drive. So with chronic smokers and COPDers, it's actually based on a low pulse ox. You, me, and everybody else, we're based off of CO2 in the bloodstream. So as our CO2 rises and falls, that determines our respiratory rate. Now, every single one of our cells, from our head to our toes, every single cell in your body requires three main things to function and make energy. Energy is ATP, or adenosine triphosphate, and the three things you need are oxygen, water, and glucose. Now, we can get into the Krebs cycle and kind of like how that all works, but for us in EMS, we really don't care. Because at 3 in the morning, you do not care about the Krebs cycle. But you definitely need to care that you need these three components in order to make energy. And if you don't get these three components, well, your body stops making energy. So if you're not making energy, you're not perfusing. If you do make energy, you are perfusing. So every single cell of your body requires oxygen to survive. Note, no ifs, ands, or buts, it's physics. You have to have circulation in order to move your oxygen cells and to carry CO2 away. So without good circulation, without good perfusion or a good intact circulatory system, you can't deliver oxygen, you can't take CO2 away. So your respiratory issues, therefore, are going to be either an airway issue, upper or lower, or an actual perfusion problem. Yes, there can be an actual lung problem where you have like lung cancer or a type of lung disease or pulmonary contusion. Absolutely, those can happen too. But for the 90% of the patients we see every single day, it's likely going to be an airway problem or a perfusion problem. And we need to try and figure out what that is. So to know what's abnormal, we got to know what normal is, right? What our normal ranges are. So for adults, they breathe 12 to 20 times a minute-ish. Children, a good way to remember is 15 to 30 times a minute-ish. And then infants, 25 to 50 times a minute-ish, right? An infant breathing 10 times a minute, is abnormal, right? We need to do something for that. An adult breathing 50 times a minute is abnormal. Now there's, take some, again, common sense into it. If you respond to, say, LA Fitness for an adult, 18, 19-year-old who just came off the treadmill, they're not going to be breathing 18 times a minute. They're probably going to be breathing 26, 28, 30 times a minute, and that's fine. But what's the respiratory rate do with rest? If they stay elevated, that's a sick patient, right? So you have to, again, look at the good and the bad with it and take in some just good common sense, and again, look at the totality of your patient. So again, SpO2 and end-tidal are two sides of the same coin. Pulse ox is terrific. It's measuring the amount of hemoglobin saturated by oxygen. It's a measurement of perfusion. It's not the only one, but it is a good measurement to say, hey, is oxygen being transported to cells? Pulse ox will tell us yes. And it's a measure of how efficient is oxygen being moved to the cells. So if I'm 97% O2 sat, I'm at 97% efficiency. That's pretty good. End-tidal measures the amount of CO2 in each expired breath. And the way this works is that we know what normal SpO2 should be, 94 to 99%. And then if I'm delivering 94 to 99% to every cell, then I have to be taking a certain amount of CO2 off of the cells. So what I'm putting in, if there's a finite amount, there must be a finite amount on the other side. And that's where CO2 comes in. So remember that our CO2 values are 35 to 45 millimeters mercury or 35 to 45 torr. So how would we do this before capnography, right? So we go to, let's say, a 74-year-old female, and she has shortness of breath. We arrived, they're standing outside a local church, pick your church in your district, and they're complaining of trouble breathing. So she's awake and alert, she's oriented, person, place, time, and events. She speaks in clear 3 to 5 word sentences, so she's a little gaspy, but not, super acute bad. Her skin color is a little pale, she's warm and dry. Well, in the old days, we just high flow O2 and transport, right? She got shortness of breath, give her some oxygen, let's go to the hospital. But realistically, is that the best way? Absolutely not. We talked about in the beginning of this that, hey, there's a lot of things that cause shortness of breath. And if I just give high flow O2 and transport, well, we'll just let the hospital deal with it. Well, the hospital has to do a lot of research and a lot of data collection, a lot of stuff to figure out what's wrong. And there's quite a bit we can do in the field to make this patient better right now. And so we should do that. So again, the problem with that is, well, there's a lot of things that cause shortness of breath. Everything that causes shortness of breath has different treatment. So our 21st century paramedicine requires better approach and a thorough assessment. We can't just throw them on a non-rebreather and transport. Not only is that a really terrible practice, it also, depending on what's going on with the patient, can cause more harm. So high flow oxygen is not always the indicated answer for every single thing you do. There are times when high flow is absolutely indicated. We should do that. There are many times we should absolutely not give high flow oxygen. We'll talk about that as we go through. So we got to identify this VQ mismatch. So what is a VQ mismatch? Well, V stands for ventilation, or in our case, breathing. So remember that your respiratory system is kind of two parts. There's the air in and air out. So you're actually moving air in and out of your body. That's ventilation. And then there's the Q, which stands for perfusion, because reasons. No set reason. It's just because medicine in Latin decides that Q equals perfusion. So, okay. Ventilation, air in and air out. Think about if you were in a room, just a regular room, and we pump that room full of propane, or we pump that room full of helium, or we pump that room full of anything else but oxygen. Your body is stupid enough to try to breathe that in. However, the perfusion side is your body will shut down pretty quickly because of hypoxia. There's no oxygen there. Your cells need the oxygen to survive. So while your body will absolutely breathe in whatever it's around, it's not going to work on the perfusion side. So again, that's why we're looking at this VQ mismatch. So what's this look like for us? Well, let's say that you had a patient breathing 26 times a minute with an SpO2 of 91%. This is a VQ mismatch. So if they're breathing fast, it would be assumed, knowing nothing else about EMS, so all of us surrender our cards for just a moment, they're breathing fast, they should have good oxygen. If you're breathing fast, you should be taking in more oxygen every breath. But in this case, the patient is not. They're breathing fast, their pulse ox is low. That is the VQ mismatch. That's all it is. Fast breathing, low pulse ox, VQ mismatch. Conversely, we got a patient breathing 26 times a minute. Their SpO2 is 98%. That's not a VQ mismatch. Not at all. That's a patient that's breathing fast. Why are they breathing fast? Couldn't tell you. We'll have to figure that out. But that's the difference between the two. So the number one thing I got to do with a respiratory patient, the first thing I got to do is identify, is there a VQ mismatch here or not? Because if there is a VQ mismatch, that is a respiratory patient until proven otherwise. There could be other things going on. There absolutely could be other things going on with our patient. But on top of those other things, there is a respiratory component. There has to be, because there's a VQ mismatch. So if you have a respiratory patient, they require certain treatment on top of the other things you might be doing. So we got to follow our respiratory protocols. So what's that proper treatment? So going back to that 74-year-old female outside that church, she's a little gaspy. So we're going to obtain our baseline vitals and determine if a VQ mismatch is present. So we're going to put her on a 3-lead. We obtain a 12-lead EKG on every respiratory patient. So, hey, she's got some shortness of breath. I'm going to make that BLS. No, you're not. That is going to be a 12-lead. So that will be an ALS run. You're going to listen to her lung sounds. You're going to put them on capnography. And then we're going to administer oxygen as needed. Because if she's sat in at, say, 93%, well, a cannula will probably do just fine. If she's sat in at 83%, well, I might start looking at a non-rebreather or maybe even CPAP at that point. It all depends on our oxygen delivery devices based on the patient's presentation. So we can't just high flow everybody. We can't just CPAP every single person or start bagging them. We administer oxygen as needed based on the therapeutic needs that they require. So we get our pulse, we get our vitals. Blood pressure is 164/74. Heart rate's 108. Respiratory is at 26, and our pulse ox is 90%. So she has a VQ mismatch, right? Again, the two things I'm looking at there are respiratory rate and her pulse ox. Respiratory rate's high, pulse ox low, VQ mismatch confirmed. She has an end tidal of 54. Now, so that's kind of weird, right? So we remember that end tidal is 35 to 45. So her pulse ox is high. Or sorry, her end tidal is high, her pulse ox is low. So I have a high end tidal CO2, a low SpO2. That's weird, that's bizarre. And sometimes in a lot of our education, we just stop right there. And we say, well, hey, that's weird, we should tell the hospital. We want to press it a little bit deeper. And here's where the rubber kind of meets the road, or the meat and potatoes of this, is understanding what's that number mean. For so many of us, we've been taught, treat the patient, not the monitor. And I would agree with you on everything with that statement, except capnography. Because capnography, you're going to want to treat that monitor. That is telling you some very, very specific things. So we get some sample history with it. Our patient has a history of COPD. She's a chronic smoker. Her trouble breathing has been ongoing for like 2 hours, getting worse and worse. And we hear wheezes down low in her airway. So she's obviously wheezing. She's having some trouble breathing. Again, if we would just high flow to went to the hospital, we would have missed all this. So we got to do a little bit more. Here's your EKG. So take a second, look at this. Think about what you're seeing. We'll talk about how to read it here in just a moment, but think about what you're seeing. Hopefully you figured out that that's a sinus beat. So if we look at lead 2, we're seeing a P wave and an upright QRS. No ectopic beats, looks pretty regular. But we start looking at like V1, V2, V3, it kind of looks a little funky, right? It looks a little elevated. V1, again, pretty elevated. 4, 5, and 6, not so much. Is it a heart attack? No, not at all. Is it concerning? Sure. And maybe we can start asking, hey, have you ever had heart problems before? Maybe she's had stents placed, maybe she's had past cardiac issues. This would be an EKG that you would see very likely in a COPD patient, especially one of her age. So nothing cardiac here, but definitely some past cardiac injury or some cardiac ailments that maybe are plaguing her. This looks like it started a little bit of a bundle branch block. So It's hard to tell with how many boxes there is if you look at the bundle branch, but looks like it might be maybe a little bit of one starting. So some to follow up with a cardiologist at the very least. But she's hypercarbic, meaning she has high CO2. Her SpO2 again is low, her respirations are increased. And so what's happening inside her body, and understand this isn't happening just in her lungs. This is happening in her liver, in her skin, in her brain, in her eyes, in her feet, in her hands. Every single cell of her body at the same time is holding on to CO2. It's not releasing it. CO2 is a waste product. Why would your body hold on to it? You're giving her oxygen, but she's not giving off CO2. That's weird. So we have to ask ourselves and take a moment of pause here and be asking ourselves, well, why is that a thing? I'm giving her oxygen. She's even breathing on her own. She's got good tidal plug. She's exchanging air. But why would the CO2 not want to come off of her cells? Is it something that she's physically doing? No. It's something that's physically wrong with her that's causing it. And that's because of bronchoconstriction. That's the wheezes you heard. So remember that wheezes equal bronchoconstriction. And bronchoconstriction means that her bronchioles off of her main bronchi going to the alveoli are constricted, which means that no matter how much oxygen you give her, it can't get to the alveoli. The alveoli being the thing that you need for gas exchange to take place in your body. So you can give her all the high flow O2 you want. It's not going to get past the constriction. Think of it this way: if your bronchioles are a roadway and your alveoli are your destination, your bronchioles are the bridge to get there. And if the bridge is out, you're not going to get there. We need to repair the bridge. This is why this patient is an airway problem. Yes, it's a pulmonary issue, and yes, it's a respiratory patient, but the fundamental cause of this is a lower airway problem. So we got to fix that. Well, if I have bronchoconstriction, she needs a bronchodilator. And when we give the bronchodilators and we give her oxygen on top of it, she's going to go back into homeostasis. And in theory, you've kind of fixed her. So we reassess her. So we give her our Duoneb treatment. We give her our 2.5 of albuterol, our 0.5 of Atrovent. We try and fire 60 of prednisone into her, or maybe we should go for the solumedrol route, the 125 of solumedrol, however, whatever you want to do as a clinician, as long as we're following our protocol there. And blood pressure comes down a little bit, nothing too significant. Our heart rate goes up a little bit, but that's to be expected, right? The side effect of albuterol is tachycardia. Her respirations decrease, and her pulse ox goes up to 96, and her capno goes to 44. And this is over the course of about 10 minutes. She starts to breathe better, she starts feeling better, and essentially you fixed her because you were able to recognize that hypercarbic state. Hey, she has high CO2, low SpO2. She has bronchoconstriction. Oh, because of bronchoconstriction, she needs a bronchodilator. And because I do that, I fix her. We see that run all the time, multiple times a week. You guys see that run every single day. So that's how you treat it. But that's understanding how capnography will guide that treatment plan. It's not just giving them a breathing treatment. Because what happens when you have low CO2, right? So if you're high, you have a lower airway issue again, right? So you have bronchoconstriction, maybe you're CO2 retentive or hypercarbic because you have pulmonary edema, right? If you have fluid in your lungs, that oxygen can't get to your alveoli. You can't breathe underwater, so we got to get that fluid out. So if you have high CO2 in that case, we need CPAP to push that fluid out of your body. If you're in pulmonary edema, you might need nitrates, like our high dose nitra, 0.8 milligrams sublingual, in order to pull that out. But in low CO2, well, that's different, right? That's an entirely different ball of wax. So we have a 24-year-old female that presents with rapid breathing and shortness of breath. She's in 1 to 2 word sentences and says she can't breathe. Her vitals are 118/72. Her heart rate's 128. Respirations are 36 a minute with an SpO2 of 99 and an end tidal of 22. So is there a BQ mismatch here? Well, the answer is no. She's breathing fast and her pulse ox is 99. Now, the outlier of this being, if your CO monitor was going off with this, then yes, there's a BQ mismatch here. But we'll assume that no, she's outside, she's in fresh air, she's not poisoned, with carbon monoxide. So there's no VQ mismatch here, which means this is not a respiratory patient. Not at all. So then what is it? Well, she's got rapid breathing with good perfusion. Maybe it's a panic attack. Now, we're not just going to dismiss that like, oh, well, it's just a panic attack, no big deal. There is a big deal, right? This patient is suffering because of her low CO2 state. She's hyperventilating, right? She has rapid breathing with no perfusion, and that creates kind of an oversaturation of cells. Basically, every single one of her cells takes in a lot of oxygen and knocks all the CO2 off. She goes into an alkalotic state. So that causes hypocarbia. That's why she gets the carpopedal spasms. That's why everything starts to lock up on her. That's why she can't process what you're saying. This patient, you're trying to calm her down, but if you tell her just calm down, well, don't you think she could if she would if she could? She probably wants to calm down. That's triggering more anxiety and more panic disorder. And the more times we say calm down, probably makes it worse. So we need to do something else, right? We need to get that CO2 to rise. In our previous patient, we want that CO2 to fall. We wanted to get, but in either case, we want to get back into homeostasis, the 35 to 45. So we know that the reason she's losing CO2 is she's breathing super fast. So how do we fix that? Well, a lot of providers would say, well, let's put her on a non-rebreather. To which I would say, she's satting at 99%. What is that going to do? Nothing. It's not going to do a thing for her. Instead, what if we slow her breathing down? Now, we can't put this patient in a brown paper bag and have her breathe that in. However, there is something we can do. So if she's supposed to be in 35 to 45 and she's breathing fast, why don't we slow her breathing down? Why don't we tell her to hold her breath? And I've had great success with this in the field. Tell your patient to take a big deep breath in and hold it as long as they can. And you're going to count to 10. Super, super slow. 1, 2. And at this point, your patient's going to exhale and gasp, and that's fine. But you're going to see that CO2 jump. And you're going to tell her she did a good job. Let her catch her breath. Hold her breath again. Count to 10. And maybe this time she gets to 5 and she exhales. But each time she does that, she's slowing her breathing down, which causes CO2 to rush back into the cells. She's going to go back into homeostasis. Her hands and all that's going to relax. And she's going to be able to comprehend and make sense of what you're saying. Because up to this point, they are not. So before we start reaching for benzos and start doping her up with Versed, try this. And then if that doesn't work, by all means, Versed your patient. So what happens if you have a VQ mismatch and hypocarbia, right? So there is a respiratory component and they're low. Well, that's weird. That's really weird because we understand bronchoconstriction. We understand that our asthma and our CHF patients will be super high because they're not able to give that CO2 away because the roadway is blocked. We understand that they'd be low in hyperventilation because they're having a panic disorder. But what happens when both these things are low? Pulse ox and CO2 is low. So I would ask if they're supposed to saturate between 94 and 99, and if it's supposed to be between 35 and 45, what causes this? Well, a hint, it is not hyperventilation. If they are hypoxic and hypocarbic, that is not a panic attack, not even close. It's shock. It's shock. So shock is a state of hypoperfusion, right? Cells are not making ATP because they're lacking oxygen, water, and or glucose or a combination thereof, right? So think of it this way. If we think that we need oxygen, water, and glucose to make energy, and I have a trouble breathing patient, well, which of these are they not getting? Oh, oxygen. So again, if my patient's not getting oxygen, we need to give it to them. If I have a trauma patient, right? So a patient, let's say, is in a bad car crash, or they've been shot multiple times, and they're bleeding out, whatever the case is. Well, they're lacking oxygen and water. They're lacking blood, though what we would refer to as water in this case, the transport medium for oxygen. So we need to stop the bleed and give them oxygen. Well, in sepsis, they're lacking all three of these. And if I give them all, one or all three of these, then they start to get a little bit better, don't they? So think about your trauma patients. Stop the bleed, give them oxygen, they at least start to stabilize a little bit. Because if we don't stop the bleed and don't give them oxygen, they do significantly worse. So remember that you have 3 states of shock. So regardless of the cause of shock, and we'll talk about those here in a moment, you have 3 states. But when you go into shock, you enter compensated shock. These patients are very, very, very difficult to identify because they look normal. Consider something like a car crash and consider our response time to those crashes. So we're there within 5 to 6 minutes. So in 5 to 6 minutes time, how much blood would you have to lose to really identify shock? What I'm saying is, if you think about your body is bleeding out, and let's use a car crash as an example, internal bleeding. Well, the only way to circulate more oxygen around your body, because you're losing it somewhere in your body, is to increase your heart rate. So your heart rate is going to increase. Because you have an increased heart rate, your BP is going to be normal. So instead of being, oh my gosh, they're super low blood pressure, no, they won't. It'll be just fine. And because my blood pressure is normal, it means I'm perfusing my brain, which means I'll be alert and oriented. Maybe a little anxious, but I'll be GCS 15. My skin color and condition are going to be absolutely normal. Maybe a little pale, but who isn't a little pale or worked up after they get into a car crash? You might see a little bit of increased respiratory rate because that's how they take in more oxygen, but their pulse ox will be normal. So the point is that these patients look just fine. And so we stay on scene, right? We show up, we do an assessment, we have a patient with a normal BP, a little tachycardia, a little tachypnea, normal pulse ox, and GCS 15. Well, is that they're worked up from the crash, or are they bleeding internally? I don't know. And you don't either. These patients look just like everybody else. So now we get a refusal and we leave. And 30 minutes to an hour later, they pass out because the blood loss has gotten worse. Well, they were in shock the whole time. We need a device that shows us a little bit better. And decompensated shock, these patients are super easy to figure out. These are your hallmark shock signs: pale, cool, diaphoretic, tachycardic, tachypnic, hypotensive, hypoxic. So 2 T's, 2 H's. They have an altered mental status, so they're anxious, they're confused. They have hallmark signs, very easy to identify. These are the patients you walk into a room, you're like, oh, yeah, that patient's really sick. We need to go. We can see this from across the room in about 3 seconds time. Irreversible shock, these patients are unconscious or very, very lethargic, heading towards unconsciousness. Profound hypotension, 60 over 30, 70 over 40 BPs. They're bradycardic, often bradypnic or apneic, so their breathing slows, they struggle, then they stop breathing. They might have mottled or ashen skin. The big thing with irreversible shock is be prepared to code them. Like, these patients are going to die in front of you or arrest very, very quickly. So pads on, get your equipment staged, be ready to rock, because those patients are going to crash. So what's this mean with end-tidal? Well, end-tidal will identify early compensated shock because of the physics of how this works. If the patient's alert and oriented, why is their CO2 low? If they're breathing fast, why is their CO2 low? Well, that's because the cell is not receiving oxygen. Their cells inside their body, all of their cells, are not receiving oxygen, not because the roadway's blocked. It's because their cells are dying, and a dying cell cannot take in an oxygen molecule. And if it can't take in an oxygen molecule, well, it sure can't give off a CO2 molecule because there's none to give off. It's dead. So the falling of CO2 translates to a falling of cells. There's not enough there anymore. Where'd they go? They die. That's That's why you get hypocarbia in shock. So, what's this look like to us? Well, we got a 66-year-old male with sudden onset shortness of breath. He began having trouble breathing 45 minutes ago. He's wheelchair bound, he's alert and oriented, with a patent airway and no audible airway sounds. He's breathing 26 times a minute. He's pale, warm, and dry. He's been ill with influenza B and RSV 2 weeks ago, but he's been taking antibiotics. History includes ALS and hypertension, so Lou Gehrig's disease. He takes multiple prescription medications. He is not allergic to anything. And when you look at his prescription meds, you do not see anything that really jumps out at you other than your basic hypertension meds, your boilerplate 66-year-old prescription pills. So we have a blood pressure of 146/86. He obviously does not look this well. Heart rate of 116, respirations of 26, pulse ox of 91. His capno is 27, and he's got clear lung sounds bilateral. What's the cause of his trouble breathing? Well, number one, again, going back to how we assess these patients, is there a VQ mismatch? And absolutely, he's breathing 26 times a minute with a low pulse ox. VQ mismatch confirmed. So I listen to his lung sounds, I auscultate, and they're clear. That rules out quite a bit. His capno is low, therefore he's not CO2 retentive. His bronchioles are fine. He's not wheezing, there's no rales. So there's no need for bronchodilators and all that stuff here. He doesn't need a breathing treatment. That's not causing this. Something else is. So if I look at our causes of shock, there are 4 types of shock, and 2 of those 4 have subtypes, and that's why it gets really confusing with this. But the number one, the first type of shock, not necessarily the most common cause, but a type of shock that we see very often, or the easiest one for us to kind of understand, is the hypovolemic shock. And that's simply lack of fluid. So your circulating blood volume has now spilled out of its vasculature. It's spilled out onto the ground because you've been shot. It's spilled out into your abdomen because of internal bleeding. But for whatever reason, the blood inside your veins and arteries has escaped those veins and arteries. Usually due to trauma, absolutely can be due to medical events as well. Another type is cardiogenic, right? So that's the actual pump problem of the heart. The heart is too weak to keep up with what's going on. The supply and demand issue, cardiogenic shock. Then we can have distributive shock, and this one is kind of hard, often forgotten about. But we have anaphylactic shock, septic shock, neurogenic shock, and psychogenic shock. Psychogenic being, it's not really a type of shock. So anaphylaxis, right? Severe allergic reaction, airway swelling, face swelling, tongue swelling, profound hypotension, hives everywhere, really, really bad stuff. Sepsis due to illness, neurogenic being they cut their spinal cord, so that's 9 times out of 10 due to trauma, right? Actually 99.99999 out of 100 due to trauma. So some type of event has caused their spinal cord to snap, which has caused a disruption in the nervous system. And then psychogenic is they passed out, like receiving bad news or seeing a grotesque sight. And obstructive shock, that's typically due to some type of an obstruction preventing blood circulation from occurring. So a cardiac tamponade, often due to trauma, a tension pneumo, often due to trauma as well, or pulmonary embolism. So because we have different types of shock, just like we have different types of respiratory patterns, each one requires various treatment. So again, even though shock treatment is, well, oh my gosh, IVO2 monitor transport. Yeah, got that. What else you doing? Because these patients need more stuff. If you just IVO2 monitor transport an anaphylactic patient, they're going to die because they need epinephrine, they need Benadryl, they need steroids, they need a breathing treatment. If I IVO2 monitor a neurogenic shock patient and don't consider C-spine precautions, that's going to make them a lot worse. So I have to not only understand shock, the types of shock, the type of respiratory patterns, all the stuff that goes into this that we've been talking about, but I have to understand how to treat those symptoms. So identify the likely cause that will contribute to successful patient outcomes. In this picture, if your patient's bleeding out, stop the bleed, give them oxygen and transport. That will work. And by the way, also keep them warm. So if they're hypovolemic, yeah, IVO2 monitor, and then fluid challenge them if they're hypotensive. If it's cardiogenic, IBO2 3 lead, 12 lead, and then consider fluids or pressors based on what you find with their lungs. In distributed shock, anaphylaxis, well, IBO2, epi 1 to 1000, IM, Benadryl, 25 to 50 IV, and then we might also be considering albuterol, atropine, steroids, and going down those lines of treatments. In sepsis, IBO2, 3 lead, 12 lead, fluids or pressors, very similar to cardiogenic shock. Neurogenic C-spine, IBO2, 3 lead, and then a focused neurological exam. What do they have working and what do they not? Try to pinpoint, if you can, at least a rough idea of where that spinal cord transection is occurring. Psychogenic supportive care, and they passed out, make sure they don't have any other injuries, remove them from the environment that's causing their distress. So if they're seeing really nasty things, get them away from that environment. Or if they've had some type of emotional trauma, just do supportive care. And cardiac tamponade, IBO2 rapid transport, 3 lead, 12 lead, because the only thing that fixes that is pericardiostentesis. Tension pneumothorax, IBO2 and decompression. And then a pulmonary embolism, IBO2, 3 lead, 12 lead, rapid transport. So back to our guy, right? So he's Capno at 27, he's still statin at 91, clear lung sounds. What's the cause? Well, based on his findings and his history, probably a PE. If we go back, let's think about it. This patient sits in a wheelchair, he's got Lou Gehrig's disease. Well, is he bleeding anywhere? No, we'd see that. Is he in cardiogenic shock? No, because he's tachycardic. Cardiogenic shock presents with bradycardia. So is he anaphylaxis? No, he doesn't have hives everywhere. His blood pressure is good. He's alert and oriented. We don't see any swelling or hives, so we can rule that out. Is he septic? Potentially. Very likely. We could take a temp on him, but his history that he was sick 2 weeks ago and he's been taking antibiotics kind of leads us down the path of maybe it's sepsis, but likely not. Is he neurogenic? No, right? He hasn't fallen off a building. He hasn't fallen 4 stories and broken his back. Did he pass out from seeing something bad? Absolutely not. Does he have cardiac tamponade? No, he doesn't have narrowing pulse pressures. Attention pneumo, clear lung sounds. So by process of elimination, this guy's got a PE. And if he's got a PE, well, there's our treatment right there. So let's look at somebody else. We got an 82-year-old female who's feeling ill in her home. She has a history of COPD. She has a history of hypertension. She's got 2 stents placed 4 years ago. She appears alert and oriented. She's got a mild cough and some trouble breathing. She states that the cough has gotten worse over the last 3 days. She appears warm, pink, and dry. All right, so again, we're looking at our patient, right? And she's got the following vital signs: blood pressure of 98 over 60, heart rate 88, respirations 20, and pulse ox 91. Her glucose is 204, her end tidal is 26. So she's got COPD, she's got hypertension, she's had kind of a productive cough. So what's the likely cause? Note that her EKG shows some AFib, right? So we got that irregular rhythm. So that's something to be concerned about. So what's causing this? Well, again, if we're looking at our elderly lady, is she bleeding out, right? Has she been shot multiple times? Has she been in a bad car crash? No. Is it a pump problem? Again, no. She's not bradycardic. She's not bradypneic. She's alert. So we're not looking at cardiogenic shock. Anaphylaxis, again, is she got hives? Sepsis, again, maybe, right? So that's one to keep an eye out for. Neurogenic, did she fall off a building or jump out of an airplane without a parachute? Doesn't seem to be a likely cause. Psychogenic, again, does she see something violent, grotesque, and pass out? No. Does she have cardiac tamponade, attention pneumo? No. Does she have a PE? No. And the difference between this patient and the last one The last patient having Lou Gehrig's disease, having a sedentary lifestyle because of a disease process. Let's say that this patient gets up and moves around. That kind of negates a pulmonary embolism. So again, by process of elimination, we can start to rule into sepsis. She's been ill, and she has some symptoms point towards distributive shock. So she's a sepsis patient. And so we need to follow our sepsis protocol. Not only follow the sepsis protocol, the IVO2, 3-lead, 12-lead, but also a sepsis alert to the hospital. So this is an early indicator that she's in compensated shock due to sepsis. And here's the thing. What if we're wrong? What if she's not septic at all? What if she's not even in shock? What if we read these values and we're totally wrong? So what? The ER can figure that out. But I'd rather have aggressive paramedics treating patients than passive paramedics treating patients, because what's the harm? What's the harm in a 12-lead, an IV, and a sepsis alert? All they're going to do is run her blood count and figure out what that is. So the thing is, you're likely going to be correct. This is a sepsis patient. But even if you're wrong and she's not septic, which would be a complete rarity in this patient presentation, so what? You have nothing to lose, so treat her. So let's look at this guy. We got a 48-year-old male. He's got abdominal pain with nausea, vomiting. He's alert and oriented, patent airway, no difficulty breathing, and he feels weak. He's pale, cool, and clammy. He's vomited, had diarrhea for 2 straight days. He has a history of alcoholism. He hasn't had a drink in 2 days. So gut feeling, hey, this is a BLS run. Nothing to do here, right? This is an easy transport, nothing wrong. But again, we need to do a deeper dive with our patients. BP 106/62, heart rate 106, respirations 22, and a pulse ox of 95. So is there a VQ mismatch? No. No, there's not. And in this case, if you put them on capnography, terrific. If you didn't, I really can't fault you, because there's not a VQ mismatch here. It's got a glucose of 167. But I'd say, why is a 48-year-old male sat just 95, not, again, 96, 97? Why is he a little low? That even there's subtle differences of a 1 or 2 percentage point matters. And so we just have to look at that. Hey, why is he satting a little low? Well, maybe it's because he's pale, cool, clammy, but why is his O2 sat off? He's got an end tidal at 26. So again, what's the harm in putting him on capnography? There isn't. There's no harm whatsoever. But by putting him on capnography, we see 26. So why is that? Well, we see this in the toilet on top of it. So we got some coffee ground emesis. So what's the cause there? Hypovolemic shock. Your man is bleeding inside. And hey, it's a GI bleed. Well, bleeding is bleeding, and blood loss is blood loss, and all of it will lead to hypovolemic shock. So each of these patients is in compensated shock until proven otherwise. Every one of those patient presentations was in compensated shock. They had low CO2 values. They were hypocarbic. And each one of those from a different cause. So we had hypovolemia, we had sepsis, and we had a pulmonary embolism, obstructive shock. Their capno is low because they cannot perfuse dead or dying cells. Oxygen can't go onto a dead or dying cell, so CO2 can't come off because there's no CO2 to exchange. The cell's dead. What capnography will do was increase our index of suspicion for shock and life-threatening conditions. And moreover, by identifying low capno values, it will improve our patient outcomes. It'll give us an insight that, hey, I think this patient might be in compensated shock, and we can treat them so until proven otherwise. If we're wrong, but there's no real harm in treating a patient aggressively, providing that it makes sense, right? Should you fire epi 1 to 1,000 into every single patient you have? Absolutely not. That is not what we're indicating or advocating for. But what I'm saying is, if we have low CO2 on top of a VQ mismatch, that is likely compensated shock until proven otherwise. So treat them as such. At the end of the day, capnography is a very revolutionary tool, but it has not been taught very effectively for what it can do. We tell everyone, hey, treat the patient, not the monitor. In capnography case, you should probably treat that number. The more we use it and the more we interpret it, the better and more comfortable you're going to be. And what that turns into is you're a better clinician at the end of the day. So we have to understand what these numbers are and interpret them. In hypercarbia, the cells will not release CO2, so they're going to be high. Their CO2 levels are going to be through the roof because of some type of a blockage in the airway, a lower airway problem. You're going to have bronchoconstriction or you're going to have pulmonary edema. So we have to get rid of that stuff in order to have the cell perfuse and bring their capno values back down to normal levels. In hypocarbia, they won't release CO2 because the cells are dead and dying. Or in the case of hyperventilation syndrome, you're breathing just too fast and you breathed all your CO2 off. But that's not what we're talking about here. We're talking about your patients in compensated shock who have a VQ mismatch and they won't release CO2 because their cells are dead and dying. Remember that your VQ mismatch is normal or fast breathing because that should equate to a normal pulse ox. But if it's not a normal pulse ox, if they're hypoxic and tachypnic or hypoxic with just normal breathing, that's a VQ mismatch. At the end of the day, we want you to use capnography. I want you to be empowered to use it. Do you need to use it on every run, right? If someone twists their knee and falls or hurts their shoulder, should you use capnography? Probably not. But if you want to, go right ahead. We provide you the tools. We want you to use the tools. But more importantly, I want you to feel comfortable in using the tools to treat our patients out there. If you guys have any questions, please get with me. Don't forget to fill out your evaluations and take the quiz. Thanks, guys. Have a good one.